It is 1:40 in the morning and you are awake again. Fourth night running, same side, behind the same eye. The pain does not throb, it bores, the eye streams, the nostril closes, the lid droops. You pace because stillness is unbearable. Tomorrow, same hour, it returns. Or your version is a one-sided migraine with a watering eye and a blocked nostril everyone calls sinus. I am Dr. Padda, and I run the Padda Institute Center for Interventional Pain Management. That is not a bad headache. It is a reflex, wired into a bony pocket behind your nose. Today you get its name and the honest limits of what we can do. Here is what happens to a person whose headache arrives with a running nose. They get sent to the wrong organ and stay there for years. A blocked nostril, a running eye, pain over one cheek, sinus disease, to a clinician with 11 minutes and a template. Antibiotics, a scan that reads normal. The published case literature is full of people who had sinus surgery, then more sinus surgery, then a tooth pulled for a reflex in neither. Nobody asked about the tearing eye, the most informative fact about you. That is not ignorance, it is throughput. Behind your nose, on each side, sits the pterygopalatine fossa behind the maxillary sinus. Inside it is the Sphenopalatine Ganglion, a junction box, not a nerve. Trigeminal sensory fibers from the maxillary division pass through it. Parasympathetic fibers arrive by the greater petrosal nerve. Pain traffic from the face enters the brainstem and drives a parasympathetic limb that relays here and fires onto your tear gland and nasal lining, releasing vasoactive intestinal peptide and PACAP. That is your streaming eye and blocked nostril. A reflex firing because your pain switched it on. Two things you were told that are wrong. The drooping lid and small pupil of a cluster attack are not parasympathetic overflow from this ganglion. They are a partial Horner sign sympathetic, the wrong system. And the vasodilation blamed for your pain is a correlate that rides along with the attack, not the engine. Quiet that ganglion and you interrupt the autonomic limb and the fibers through it, but not the brainstem generator, and everything honest here follows from that. Before anything goes into your nose, separate danger from pattern. Thunderclap onset, worst of your life, peak in seconds, is an emergency tonight, as is fever with a stiff neck. A first severe headache after 50, any focal deficit, any headache after head trauma, worked up, not injected. Then separate the primary headaches. They are a family, the trigeminal-autonomic cephalalgias, and not interchangeable. Untreated cluster attacks run 15 to 180 minutes, up to 8 a day, one-sided, orbital, restless. Migraine runs 4 to 72 hours and you want to lie still. Paroxysmal hemicrania imitates short cluster attacks, but answers absolutely to indomethacin. Two more belong on that grid. Hemicrania continua is one-sided pain with the same autonomic signs that never fully switches off, and it too answers absolutely to indomethacin. Miss it, and you have injected a headache a tablet would have ended. SUNCT and SUNA are stabbing attacks lasting seconds to minutes, dozens or hundreds a day, answering to sodium channel drugs like lamotrigine, not to this ganglion. A block is not first line, and I will not pretend it is. If nobody has put you on high-flow oxygen through a non-rebreather mask, offered an injectable triptan, or started a real preventive, the hole in your care is upstream of anything I do. Fix that first. The block is for the person who has done those things and is still losing their nights. The block itself. 3 ways in, and they are not equivalent. Transnasal is the least invasive, and there are 2 versions that are not interchangeable. The older one soaks a cotton-tipped applicator in anesthetic and parks it against the mucosa. Cheap, common, no placebo-controlled data behind it. The version tested in both randomized trials used a small intranasal applicator delivering a measured 0.3 of a cubic centimeter of 0.5% bupivacaine per side past the posterior tail of the middle turbinate, where about a millimeter of mucosa separates drug from ganglion. No needle enters tissue either way. I use the tested one, and I tell you what you are getting. Transoral goes through the greater palatine foramen in your palate. Percutaneous enters below the cheekbone through the coronoid notch under live fluoroscopy, contrast confirming spread, most precise, highest risk, because the maxillary artery shares that space. No local anesthetic is FDA approved for treating cluster headache or migraine at this ganglion, and the intranasal applicators are cleared to deliver medication, not for a headache indication. This is off-label, and you are entitled to hear that word before you consent. Patients ask about diet and supplements. A ketogenic pattern, omega-3 derived pro-resolving mediators, and 660 to 850 nanometer light are investigational in cluster headache and migraine. No randomized trial shows any of them shortens a bout or aborts an attack. I will track them in your diary, and I will not let them displace oxygen, a triptan, or a tested preventive. Now the part the brochures leave off, what the randomized trials found, including the one that failed. A double-blind, placebo-controlled pilot by Katie and colleagues in Headache, 2015, gave chronic migraine adults repeated transnasal bupivacaine or saline. Pain scores were lower with bupivacaine at 15 and 30 minutes and at 24 hours. 38 patients finished, allocated 2-to-1. The entire placebo comparison rests on 12 people, run with one commercial intranasal device. The author's own word was promise, and promise is not proof. Schaffer and colleagues, in Annals of Emergency Medicine that same year, randomized 87 emergency department adults with undifferentiated acute headache. Not migraine, not cluster. The primary endpoint failed. 48.8% versus 41.3% reached 50% relief at 15 minutes, an absolute difference of 7.5%, confidence interval -13 to +27. Its 24-hour advantage was secondary and unadjusted. Ho and colleagues in the Journal of Headache and Pain in 2017 found only 23 of 83 publications above case series level, and their headline, "Strongest evidence here is in cluster headache, WISE, pools blocks with radiofrequency ablation and implanted stimulation, and rests on small, unreplicated studies." Say the uncomfortable part out loud. There is no randomized, placebo-controlled trial of a sphenopalatine ganglion block by itself in criteria-confirmed cluster headache. Not one. The only placebo-controlled block data in a defined headache population is that 38-patient migraine pilot. The rest is uncontrolled case series or ablation and stimulator trials, different procedures, different risks, not evidence for an applicator. I grade this evidence low, and I still offer the block to selected patients. Relief runs hours to days from one block. A series may extend it to weeks. It is a bridge that buys a window, not a cure. The risks: common and temporary, bitter taste, numb palate, nosebleed, nausea, and a vasovagal blood pressure drop. Needle approaches add cheek numbness, maxillary artery puncture with hematoma, rarely bleeding behind the eye or double vision, infection, and seizure if anesthetic enters a vessel. We defer with active nasal or sinus infection, anticoagulation, or anesthetic allergy. What I'm about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. A man in his 40s. Bouts arriving every spring and every autumn, several attacks a night, always the same side, and behind him a decade of treatment for sinuses and teeth. What helped first was not a procedure. It was a diagnosis and a diary that made the timing undeniable in 2 weeks. What went in first was oxygen, a tank and a non-rebreather mask at high flow, which nobody had handed him in that decade. An injectable abortive and a preventive titrated against an electrocardiogram. The block came after as a bridge while the preventive reached dose. His attacks shortened, not vanished, shortened. The first block did almost nothing he could measure. The second, better placed, bought about 2 days. He had a nosebleed. The bout still ran most of its course. If 3 blocks changed nothing durable, we would stop rather than escalate. If your headache comes with a watering eye and a blocked nostril, you deserve first not an injection, but a physician who times the attacks, excludes the dangerous causes, and names what you have. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Start the diary tonight. Write down the hour. The pattern is the diagnosis, and only you can record it. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.